Greetings and welcome everyone to today's webinar. My name is Elena Kennedy and I'm the Chief Operating Officer here at the Illinois Association of Medicaid Health Plans, also referred to as IAMHP. Today's webinar is in partnership with the Illinois chapter of American Academy of Pediatrics, and we are very grateful to have them on in partnership for today's webinar. As our attendees are joining us today, we're going to take a few moments to walk through the logistics of the platform that we're utilizing today, and then we'll dive into the presentation portion. For those of you who are viewing this live, you'll note that IAMHP utilizes the GoToWebinar platform. Thus, a GoToWebinar control panel should be on the right-hand side of your computer screen. Hopefully at this point, all of you are able to hear me. Should you or any of your colleagues experience any audio or technical difficulties, please submit those to me via the questions tab. In the meantime, though, hopefully all of you, as noted, can hear me. Please note, though, if for any reason you lose audio connection, you can move between your computer audio or your phone audio. Should you use your computer audio, though, you may need to give permission to the platform and the computer. Once again, though, technical questions can be directed towards me via the questions tab. Additionally, though, we will be moving through a lot of different material and information today about vaccines and vaccine hesitancy. So you can submit those to me via the questions tab. I'll answer a few of those along the way, but then we'll be pulling the rest of those for the Q&A section at the end of today's presentation. Additionally, we have a chat tab, which is a wonderful tool for you to create community with the other attendees, as well as connect with myself and our panelists today. Please note that due to the version of GoToWebinar you have, or to your firewall protection at your organization, you might not be able to access the chat function. We apologize for that inconvenience, but truly appreciate your understanding in this. Without further ado, let's move forward with our presentation today. As noted, my name is Elena Kennedy, and I'm the Chief Operating Officer here at the Illinois Association of Medicaid Health Plans, also known as IAMHP. As a trade and member organization for the Medicaid Managed Care Health Plans, we work with the Illinois state government, legislators, advocacy groups, providers, and other groups who support this space to invest in and provide high-quality health care focused on cost-effective, individualized care that helps the residents ultimately live longer and healthier lives. But as we all know, improving healthcare delivery systems is a never-ending job, and that's why we work with our members and industry partners to achieve better health outcomes. And which is why we partnered today, actually, on this important topic with the Illinois chapter of American Academy of Pediatrics. And I am so excited and grateful that we have Dr. Chandra here today. Welcome, Dr. Chandra.
Thank you.
With that, I know that you are very accomplished, and so I'm just going to detail a few of those things for our listeners today. Before we dive into our presentation, she has been a pediatrician with Northwestern Medical Group in Chicago since 2001. She received her MD from Northwestern University's Feinberg School of Medicine in 1995 and completed her residency at Northwestern's Children's Memorial Hospital. Dr. Chandra maintains a strong affiliation with the medical school as an instructor in clinical pediatrics at Northwestern University, and over the years she has worked in various capacities with the Illinois chapter of American Academy of Pediatrics, including the Executive Committee, the Committee on Infectious Disease and Immunization, and the Task Force on Anti-Racism. She is a champion of childhood immunizations and is a media spokesperson for the AAP and Northwestern Medicine. And she is married with 4 teenage sons and enjoys reading, dance, and travel. And I know, unfortunately, you probably haven't had as much travel lately, but hopefully are also enjoying the summer. So we truly appreciate you taking an important hour out of your day today to help educate the collective and on this important discussion.
Thanks again.
With that, before I hand it over to you officially for today's presentation, I just would like to also note that this does not happen. These conversations will not just be ending today. We know that there's constant conversations happening within this ecosystem to help support this space. And we know that you might want to review this webinar again. I just want to note, as I'm already receiving questions on this, we will be sending around a recording of today's presentation to all of our registrants today so that you can re-listen to this recording, and we'll be posting it on our website as well, as we know that their parents' attitudes and intentions about vaccines, fall along a continuum from complete refusal to complete acceptance of all recommended vaccines. And so there's a lot of conversations about, hesitancy. And we know that pediatricians and other healthcare providers and professionals who are on today play a key role, in empowering parents to make vaccination decisions and providing information and education. And we want you to have this information. So yes, we will be sending around a recording of today's presentation. And so with that, I'm going to step back and actually allow our panelists today to step up and present. So with that, welcome, Doctor.
Thank you. I am going to ask you, Elena, to just be advancing the slides for me. So I'll just say next. And I'm happy to answer questions at the end of this presentation. To Elena's point, this is a constant conversation for anybody who is in the vaccine space. And so please do think of your questions and think through even examples of how you've had to work with this in the past, and maybe how you can improve your delivery of or improve the situation in the future. So next slide, please. I do not have any financial relationships to disclose. Next slide. So our learning objectives today are to define vaccine hesitancy, to address the common myths around vaccines, to educate you and each other about Illinois religious and medical exemptions, and to share strategies for talking to parents and others about vaccines. Next. One of the greatest public health achievements of the past century really has been the development of vaccines. And we know that they are cost effective, that they prevent millions of deaths annually. And if we were to actually have vaccine availability globally the way we would want, global coverage of vaccine availability, we could perhaps prevent even more deaths. Somewhere in the order of 1.5 million more deaths could be avoided if global coverage of vaccinations improved. Next. So, while we know that immunizations are absolutely essential, there have been things that have caused disruption to routine immunizations. And we're going to talk a little bit about the current pandemic and immunizing against COVID, along with immunizing against other vaccine preventable diseases. Unfortunately, this disruption in immunizations due to the pandemic and social distancing and not reaching out to healthcare providers for routine care has resulted in decreased immunization rates across the world. But if we look at here in Illinois, certainly decrease in immunization rates, increasing the number of people susceptible to outbreaks of vaccine preventable diseases. Let's talk about what vaccine hesitancy is. Next slide, please. So according to the World Health Organization, vaccine hesitancy refers to a delay in acceptance or refusal of vaccines despite availability of vaccination services. Vaccine hesitancy is complex and context-specific, varying across time, place, and vaccines. It includes factors such as complacency, convenience, and confidence. This term emerged to depolarize the pro versus anti-vaccination alignment and to really express the spectrum of parental attitudes toward vaccines. That's the important thing to keep in mind, that there is a spectrum for vaccine hesitancy. Next slide. The World Health Organization, I think we are one slide ahead. The World Health Organization says that the anti-vaccination movement has been a significant factor in the rise of deaths in preventable diseases. And if we look at a few of the top 13 urgent health challenges for the next decade at the World Health Organization surrounding vaccines, one of the #1 things is to re-earn public trust. Trust helps to shape whether patients are likely to rely on health services and follow a health worker's advice around vaccines, around taking medication, around screening for other illnesses. Another significant goal of the World Health Organization, of course, is to stop infectious diseases. Meanwhile, vaccine-preventable diseases continue to kill, such as measles, which took over 140,000 lives in 2019, and polio, although almost on the brink of eradication, still we see wild poliovirus cases. There were 156 cases last year, the most since 2014. And of course, another significant function of the World Health Organization is to prepare for epidemics. Next slide. Over the past decade, acceptance of vaccines has been challenged by individuals and groups who question their benefit. Increasing numbers of people are requesting alternative vaccine schedules or postponing or declining vaccination. As a pediatric healthcare provider, I don't believe that there are alternative vaccine schedules. There is one vaccine schedule that has been created, studied, and published by the ACIP and the CDC. There have been many studies providing evidence of an increase in parents being hesitant or refusing vaccines. In a national telephone survey of 1,500 parents of children 6 to 23 months of age conducted in 2010, approximately 3% of respondents had refused all vaccines, and about 20% had refused or delayed at least one of the recommended childhood vaccines. Next slide. When we talk about complacency and lack of confidence, and we talk about complacency, inconvenience in accessing vaccines, and a lack of confidence as the key reasons underlying hesitancy. A lot of our patients and parents access other sites besides coming to their primary care physician or provider, healthcare provider, for getting information about vaccines and healthcare. Social media, while it has many advantages, also serves as an echo chamber. And there's a large amount of information that parents and patients are able to access, which may be in direct opposition to what your primary healthcare provider is suggesting. As an echo chamber, when people are looking things up, it tends to be that the filters end up giving them the same information, leading them down the same path that they were already thinking about. So when we think about large amounts of information in opposition or false information, what parents end up feeling or expressing are that vaccines may be a threat. They share with each other different strategies to avoid vaccination. And then because different parents and patients are actually accessing this, more and more people are becoming exposed to anti-vaccine messaging. Next slide. Traditionally, when we think about demographic segmentation of the vaccine hesitant people, this also is in the same category as the COVID-19 vaccine hesitant people. We typically look at things like gender, geography, race, party affiliation, and income. And previous studies of COVID-19 vaccine confidence have really focused on these demographic groups, finding that women, rural residents, Black individuals, Republican Party followers, and lower income individuals and essential workers tend to express lower likelihood of vaccine uptake. But I challenge you to actually look at COVID-19 and other vaccine hesitancy using different sort of groupings. Next slide. This actually may be a better way to look at this. This is more based upon psychobehavioral segmentation, where you have your enthusiasts, you have your watchful patients and parents, you have your cost-anxious people, you have your system distrusters, and you have your COVID or other vaccine skeptics. And if you look at, there are people who fall within from different demographic categories in these different segmentations. So I think that this may be a little bit better way to view vaccine hesitancy, because people are more complicated than simply their gender, their race, their political party, or where they live. And so targeting solely based upon those prior demographics really can miss the underlying barriers that shape a person's intention. And these barriers are really malleable and multidimensional and may help us actually figure out better ways to approach our patients and parents who are hesitant. Next slide, please. I'm actually going to have you go to the next slide. So we're going to talk a little bit about common vaccine myths. And perhaps different ways that we can address them. Next slide. So one of the most significant vaccine myths that has challenged pediatric vaccine providers has been the myth that vaccines cause autism. Another significant myth that parents and patients may bring up is that vaccines contain harmful ingredients, including things like mercury or thimerosal, aluminum, or formaldehyde. It's very important for us as the pediatric or the vaccine providers to really have good knowledge base about these myths and to think about how you can actually have conversations with your patients and parents refuting these myths. So let's take the first one, for example, MMR vaccine and autism. You know, a common concern that you may hear is whether the MMR vaccine causes autism. It's important to stress that there has been so much research showing that the MMR vaccine is safe and does not cause autism. This myth began when a doctor in the United Kingdom named Andrew Wakefield published a study in the medical journal The Lancet in 1998, claiming a component of the MMR vaccine led to autism in children who were vaccinated. No other researchers were able to reproduce this finding. And in 2010, the article was actually retracted from The Lancet. Wakefield's conclusion was further undermined by the fact that his research was funded by lawyers looking for evidence against the vaccine industry. As early as 2004, 10 of the 13 additional authors of the paper retracted the hypothesis proposed. And we know in 2011, Wakefield lost his medical license and was permanently barred from practicing medicine in the UK. Unfortunately, he continues to lecture on the topic and spreads fear and misinformation. And for those of you who were vaccine providers in the previous decade, so in the decade, the 2010 to 2020 time period, know how much this myth actually created a lot of extra work for us, a lot of challenge in terms of having conversations with patients and parents about the safety of vaccines, that international and national bodies of science had never been able to replicate any connection between vaccines and autism. And in my experience, this myth has actually come down in terms of what parents and patients are expressing to us. But it really challenged the notion that vaccines were safe. The next myth about vaccines containing harmful ingredients, it's very important as vaccine providers to know what the purpose of various ingredients are in the vaccine. Of course, there are the antigens, the proteins that are necessary to provide immunity, but then there are some that are considered preservatives, some that are actually present in the most minuscule amount or were present only in the preparation of the vaccine, but were washed and washed and washed out of the vaccine product. However, because they were at one time present, they have to be listed in the package insert or in the ingredients. It's also very important to understand the differences in types of the inert or preservative ingredients. Mercury, for example, knowing that there are two different types of mercury, methyl mercury, which is found in certain kinds of fish and high exposure levels, which can be toxic to people. However, ethyl mercury, which is actually what is used in vaccine production, is not in that toxic category. Thimerosal was removed from vaccines because of the concern for any kind of toxic effect, but most healthcare providers know that the preservatives that are used, the aluminum and the amount of formaldehyde that's used in preparation, aren't in amounts present in the vaccine to actually cause harm to our patients. So it's important to be able to have these conversations with your patients and to understand where in production some of these ingredients come into play. Also, like in my practice, we know the different manufacturers of our vaccines because some parents will actually specifically ask us, which product do you carry, because they've done their research on which vaccine product they actually want for their child to have. Next slide. Other vaccine myths: too many vaccines in a short period of time, or that vaccines do not have enough rigorous testing and monitoring. Again, these are things that you as a vaccine provider need to be able to have conversations with parents about. In terms of too many vaccines in a short period of time, this is something that has been tested and put together. The vaccine schedule has been tested and put together by the ACIP and the CDC, and validated or supported by the AAP and the American Academy of Family Physicians, because what we're trying to do is to vaccinate our patients at times when they are the most susceptible to these diseases. And there are many boosters that have to be given in order to actually create a good level of immunity in our patients. So it's really important for parents to understand that. It's also very important for parents to understand, parents and patients to understand that the reason, or that these vaccines are so different than the vaccines of maybe 30 or 40 years ago. These vaccines have far fewer antigens because they have been able to improve the quality of the vaccine such that they have to just have very, very specific protein antigens necessary to create immunity, as opposed to the larger proteins that were present in vaccines from years ago. In terms of vaccines not having rigorous testing and monitoring, that is simply untrue. Vaccines are studied rigorously in production. They're studied in trials prior to being licensed. And there are, of course, observation periods during the trials and post-trial to make sure that we are collecting any concerning data on vaccine side effects. So it's important, again, to speak from a place of confidence and a place of understanding in order to dispel these vaccine myths with your patients and parents. Next slide, please. We kind of side tour a little bit here to talk about the COVID vaccine, because this is something that parents ask a lot about, is what is emergency use authorization? The FDA, which actually licenses vaccines, sets very specific scientific standards of vaccine safety, effectiveness, and quality. And in certain situations, like the COVID-19 pandemic, the FDA may have to allow use of unapproved medical products in an emergency. These are, the emergency use authorization is used when there are no adequate, approved, and available alternatives. And that's really important for patients and parents to understand, that there still is research that's being done, there still is trial data, and the FDA has to utilize all the best information it has at the time present to provide authorization for a vaccine. Next slide, please. A couple more vaccine myths. Natural infection is better than immunization, and the number of vaccines and antigen loads causes an immune overload. I'm not sure that anybody can specifically say that natural infection causes better immunity than vaccination. Unfortunately, the price paid for natural disease can also include things like paralysis, permanent brain damage, liver failure, liver cancer, deafness, blindness, loss of limbs, or death. These would be seen in things like polio, measles, and meningitis. So in that situation, I would say that immunization is better than getting natural infection. In terms of antigen overloads, parents are concerned about the increased number of vaccines children get now, and that the antigens contained in these vaccines will overwhelm a child's immune system. And as I said earlier, the total number of antigens the immune system must recognize and react to has significantly decreased as the vaccines have become purer and purer products. Next slide, please. We're going to turn our attention to the Illinois religious and medical exemptions, so that you know specifically who can exempt out or petition to not get vaccinated. Next slide, please. This is a really interesting wheel of the different states and who allows medical exemptions, philosophical exemptions, medical exemptions. This is a bit outdated, but you can see the bigger picture here is to understand that every state has done things differently. And so we're going to focus specifically on what Illinois has done. Next slide. In 2015, Illinois actually passed a law which does not allow for personal or philosophical exemptions. So prior to 2015, patients could present asking for a medical exemption, a religious exemption, or a philosophical exemption. And we know at the time the philosophical exemption could just be, I don't want to have the vaccine. So after a lot of debate and conversation and data collection, The Illinois Advisory Committee on Immunizations, along with support from various other stakeholders in Illinois, were able to pass a law that does not allow for any personal or philosophical exemptions. Parents who object for religious reasons actually must submit a very specific certificate of religious exemption now, which actually requires a visit to the healthcare provider, a signature from the healthcare provider, and that the healthcare provider has to confirm that they provided education to the family about the reasons for vaccination. Next slide. This certificate, which is available online through Illinois State Board of Education and IDPH, actually has to be submitted to the patient and parent, or to the patient's local school authority prior to entering kindergarten, 6th grade, and 9th grade. And then the local school authority actually makes determination if that certificate has been accepted and informs the parent. Next slide. So this specific physician statement of immunity is used when a child is already protected against a disease for which immunization is required. The statement of immunity indicates, I'm sorry, we're going to talk about medical exemptions in Illinois. The medical exemptions are used when a child is already protected against a disease for which immunization is required. The statement of immunity indicates the reason in writing and proof of immunity when available, plus the healthcare provider's signature. And then this statement of immunity is attached to the certificate of child health exam, which is the standard school form. The school forwards a copy of this to IDPH. If it's approved, the student is considered protected and in compliance. And if it's denied, then the patient requires immunization. Next slide. And then continuing on with this, if there's a medical objection or a medical contraindication, the healthcare provider needs to attach a statement to the certificate of child health exam form citing the reason. And then again, this gets sent to IDPH. The statement has to be endorsed and signed by the healthcare provider. The child care facility or school informs the family of outbreak situations and control exclusion procedures. So if there's an outbreak in a certain school and the child has not been vaccinated against that vaccine preventable disease due to a medical objection, then the school will inform the family, and the child may have to actually be excluded from school for a period of time, or if the medical condition changes and immunization is no longer contraindicated, then the immunization requirement can be met. Next slide. This, I think, is really the heart of the matter, is talking about vaccines. I think the point brought up earlier by Elena about making sure that this is a constant conversation is really where we can do the most to help our patients. So next slide. I think it's really important to pat yourselves on the back and to understand that you as healthcare providers are really and should really be the most trusted source of information on vaccines for all of our parents and patients. Study after study has shown that the decision to vaccinate is positively influenced by a primary care provider. Parents tend to follow pediatricians' advice about vaccines, and confidence about advice correlates with an increased vaccine uptake. It all makes sense. If parents and patients have been coming to you for years and you speak to them in a positive way about the vaccines and that you trust them and that you endorse them, parents will respond positively to that. Next slide. It's important to remember that the common goal here is really you and the parents want the best for their kids. So you're trying to build a partnership with the parents and the patients. It may help to share personal stories with your families. It's important to take advantage of the early opportunities that you have with these families to build their trust and to talk to them about the future vaccines that you're going to be endorsing or you're going to be providing for their child. It's really important to take time to listen to the families and to give them your full attention, to walk into the situation knowing that, again, you both have a common goal to do what's right and healthy for your patients. And it's always very, very important to focus on the positives of the vaccines. I think there are always conversations about risk and side effects and true risk of exposure and illness. And I think it's important to have those conversations, but to always present what you can in a positive light. Next, please. When I start out with my families, I like to actually welcome their questions. I want to know where they're coming from when it comes to vaccine hesitancy. It really helps to keep the conversation going. It makes them feel like I'm listening to them. I think every parent wants to sort of be in charge of what's happening for their child. And so it really helps to have that back and forth conversation, again, with my spin that this is what I want to do, but to acknowledge that they may have questions and that I want to be able to answer them, respecting their fears and respecting their feeling of wanting that authority. And a particular side note here, or particular note, is that we really want to be working on the fact that we need to rebuild trust with groups that have been historically mistreated. And that's part of where it really does help to welcome questions from families, because you don't know where they may be coming from. Perhaps it's a family where somebody told them a story of somebody having a very bad side effect from a vaccine, and so they are fearful of the vaccine and they want to be acknowledged. They want that fear to be acknowledged. Perhaps it's from a fear point of being a marginalized group that was experimented on. And that would be another situation where you want to make sure you understand where somebody is coming from. Perhaps it could be from a religious concern, or a fear that somebody in their religious ecosystem or in their religious world may look down upon them for what they are choosing to do to protect their child. Again, a situation where you want to acknowledge their fears and their concerns and have a good conversation with them about what they're thinking. Next slide, please. So one of the things that we like to focus on is to have a presumptive conversation about vaccines versus a participatory conversation. Instead of saying to them, what do you want to do about your shots today, which already puts, while it puts some level of authority in the parent's hands, it makes them feel, studies have shown that it makes parents feel that they're going to have to make big decisions, and they would rather be guided by their healthcare provider. So instead of saying, what do you want to do about shots today, I would suggest saying something like, today your child is due for 2 vaccinations. We will be giving the MMR and the varicella vaccine. Start out with that conversation point, then go on to explain the vaccines, what they protect against, what the potential side effects are, and why you recommend the vaccines. Next slide, please. If we look at the way to talk about it, if you start out assuming that parents will vaccinate and you talk to them about the vaccines you want to give them for the day in a positive way, the parent can choose to consent with no further questions, and then you administer the vaccine doses. If the parents are not ready to vaccinate, you want to give your strong recommendation about why you're recommending the vaccine, why it's safe, why it's useful, and the benefit of the vaccine. Again, maybe the parent now may take your recommendation and administer the vaccine dose. If parents still have very specific questions or concerns, you want to make sure you take that opportunity to listen to them, to respond to their specific questions, and hopefully with that time spent with them, you will be able to convince them that that is the right thing to do for their child, and then get them vaccinated that day. Next slide, please. This is another way to think about vaccines. Oops, there we go. The CASE method: corroborate, about me, science, explain, and advise. So corroborate is acknowledging concern and finding common ground. Again, you're there for the best outcome for your patient, for the best health outcome for your patient. You want to talk up in terms of about you, the healthcare provider. How is it that you've built knowledge and expertise on this? What has been your experience with the vaccine? How, where did you, what are you citing? What sources are you citing? In terms of the science, explaining the evidence behind why the vaccines are being given and are necessary for your patient. And then explain, advise, again, give your evidence-based recommendation. Next slide. Here are some examples of ways to do this sort of CASE method. Corroborate. I understand why you might think this. There's a lot of information online and in the news about vaccines and autism. About me. I always make sure I have the most up-to-date information on vaccines, and I have researched this thoroughly. Science. There is no scientific evidence to link vaccines and autism. The American Academy of Pediatrics, the National Institutes for Health, and the Institute of Medicine all agree that vaccines do not cause autism. Explain or advise. Vaccines help maintain health and well-being. They prevent diseases that cause real harm. choosing not to vaccinate does not protect children from autism, but it does leave them open to diseases. I would recommend that your child receive their vaccines today. So it's a conversational approach, similar to how you would have a conversation with a friend, perhaps, but you are and you should be presenting yourself as the authority on vaccines in this healthcare setting. Next slide. So going back to the example that I gave of the different ways of looking at those who people's approaches to vaccines, the enthusiasts, the watchful, the cost anxious, the system distrusters, and the COVID skeptics. You have to think about how you're going to approach different groups. Certainly the enthusiasts, I think, you know, if you actually say this is the vaccine that we're going to be doing today, they've already walked into the situation knowing that they're going to trust their healthcare provider and they want to do the vaccine. Then there are the COVID skeptics on the opposite end, or the vaccine skeptics, who really are not going to necessarily be convinced in that day or persuaded in that day. But I would rather focus on the three middle groups: the watchful, the cost anxious, and the system distrusters. Those seem to be the three different personas of people where I feel like we have the most chance of affecting or changing their thought process. If you look at the next slide, that will actually give us a little bit more detail on how to do this. For example, if a barrier for the enthusiast is appointment availability, well, that's a simple thing that we can fix. We can make it easy for them to get the vaccine. We can have improved hours. We can have Saturday appointments. We can have more flexibility for locations. Those are simple and easy fixes. For the watchful, the barrier seems to be community norms. So what can we do? We can talk about what the rates are for vaccine acceptance in your community, whether it's specific to a city or a state or the subset community that that individual is coming from. That also may help with vaccine safety concerns when you talk about the rates of vaccination and any of the rates of side effects in your local area or nationally. If we look at the cost anxious, if financial costs, time, and vaccine safety tend to be barriers, well, then again, we want to think about ways to bring vaccines to people. Perhaps we have to allow certain people to have paid time off to get their vaccines. Perhaps having vaccines at school locations would make it easier. Perhaps having vaccine clinics where both a child and a parent can get vaccinated would make it easier. In our office, for example, when we do flu shot clinics, we make it as easy as possible for everybody. We have weekday hours, we have weekend hours, we actually have like a Saturday clinic where we vaccinate entire families. In terms of the system distrusters, if trust, access, and inequity and vaccine safety, again, are issues, then you really want to listen and work with them. You want to partner perhaps with a trusted community member, perhaps going to a community that you are affiliated with and speaking to them about the safety of vaccines. We have a healthcare provider at Northwestern in the adult medicine world who actually went to a couple of Black community churches to really speak to the congregation about what she knew as a healthcare provider in terms of safety, and to really sit there and talk to people about what their concerns were so that they actually would, one, feel comfortable talking to her and then really appreciate her response back. So that's another way to perhaps affect the system distrusters. In terms of the COVID skeptics, there are, and other vaccine skeptics, there are some people who have deeply held beliefs against or around COVID-19 or around influenza vaccine. And they also, another barrier in their mind is vaccine safety. Sometimes it's really difficult to actually debunk some of those myths for those people. And it may just take time and constant conversation, but I'm not sure that those are the people that I would spend the most amount of time focusing on. I would actually focus on the left 4 groups, because I feel like that's where you can actually make the most significant difference and change. Next slide. It's always important to document in your chart about the questions and concerns from a family, what your follow-up plan is. You want to think about catching any kind of missed opportunities. We certainly think about vaccines at primary care visits, but as children age or into their adolescent time period, or with adults, they may not come in for primary care visits. You want to make sure that you're looking at every opportunity to vaccinate if possible. In certain situations, you can have standing immunization orders. For example, if there's a booster dose of a meningitis vaccine, you can put in the standing immunization order. Similar to HPV vaccine, you can have the booster doses ordered ahead of time. We already talked a little bit about extended immunization hours, but that really makes things easier for families. And having vaccines at school clinics also really can make things easier for families. Next slide. In terms of handling refusal to vaccinate, from a parent's perspective, a parent really has to tell, like, if their child is not vaccinated against various vaccine preventable diseases, it's a parent's responsibility to tell their healthcare provider that they haven't received the recommended vaccines. This is important because their child may need to, the healthcare provider may need to consider vaccine preventable diseases in the diagnosis or in the differential when a child presents to them for, let's say, a fever or a rash. We also, as healthcare providers, need to know that a child is under immunized because we have to take precautions to protect our other patients from vaccine preventable diseases in our office settings. If there's an outbreak of a vaccine preventable disease, the child needs to be taken out of school or childcare until it's really safe to return, and that's going to be a responsibility of the parent to have. If a child is exposed to a vaccine preventable disease, the parent really needs to seek immediate medical help and alert a healthcare provider to the vaccine status. So these are all things that you as a healthcare provider have to discuss with the parent. They're going to have to take on this responsibility since they are refusing to vaccinate their child. Next slide, please. In terms of the healthcare provider's responsibilities, I know that this is a little bit of a controversial topic in terms of in terms of deciding to exclude a child from your practice. I think it's always important to keep in mind that the child may not be any part of the decision-making process to not get vaccinated, and we certainly don't want to leave our children out there without good healthcare coverage. If it is a practice policy that you have put into place and have discussed with the family from the get-go, that is a different story, I think. If you have a policy that after, let's say, 6 months, if a family has decided not to vaccinate, then you may not be the right practice for that family, because if they don't trust you about this very important part of healthcare, maybe they won't be able to really develop a good relationship with you about other healthcare issues. If you do decide that you're going to be excluding a child from your practice because of failure to vaccinate, it's important to let the family know of other places for healthcare coverage for their child. As a healthcare provider, it's important to educate your parents and patients about the signs and symptoms of vaccine preventable diseases, and that a child can get a disease from people who appear healthy if for some reason that healthy person is a carrier of the disease but not actually getting infected themselves. And the bottom line of all of this is to continue the dialogue to the next visit, to keep having conversations about about the importance of vaccination, and to hopefully persuade a family to vaccinate their child at another appointment. If you're a member of the Academy of Pediatrics, we have a vaccine refusal form that you could download and put into your electronic medical record system as well, to document that a family has refused to vaccinate their child against something that you have educated them about. And then here are the next slide, please. Here are some more resources from the AAP and the CDC regarding vaccine conversations with parents. This is clearly a very hot topic in all of pediatric medicine, but clearly a hot topic now with COVID vaccination, and then always a hot topic with flu vaccination. I encourage you to think about how you want to approach families. It is always, it's trying, it's frustrating, but it's also very, very rewarding when you've convinced a family that this is the right thing to do. Perhaps practice with your colleagues, perhaps practice with younger trainees so that they understand how to do this. But it's really important to be the positive influence on your patients, and in the vaccine world to be the strongest advocate for vaccines. Thank you so much for your time. I'm sorry this really was sort of a lot of talking, and I do hope that some of this will stick and will inspire you to have more conversations with your colleagues about vaccine hesitancy and ways to combat vaccine hesitancy.
With that, I am just wanting to pause and say thank you so much for this overview and discussion today. While yes, there was a lot covered, and I know that we're going to take this question and answer time period to peel back some of that, dive deeper into a few items that were mentioned, and also highlight a few other things. I just want to say thank you once again for taking an hour out of your day today to walk through with all of our attendees today and those who are viewing live as well to the recording of this. You know, as I think we've had discussions with the chapter about how now more than ever, you know, there's a lot of work being put into maintaining the health and safety of Illinois children in our society and our communities. And the pediatric and providers are, you know, a very important part of that. And not only must they combat the virus itself, but must also address the ongoing child health related issues among their patients, and all this while adjusting practices and policies to keep offices open in the safest way possible, you know, for infants, children, adolescents, and the families and parents that they're serving. So today's conversation is just one of many of these conversations. And I know that many of these conversations have been had via the health plans and providers and community advocates, lawmakers, and the department on this important subject. And I'd be remiss, I would love to highlight 3 different other resources that are being leveraged and used and talked about as well before we dive into the question and answer section. So please continue submitting those questions via the questions tab. And while people are doing that, you know, I'd also love to elevate and highlight, as these conversations are happening and practices and pediatricians are having discussions internally, I'd also like to elevate that the Illinois Association of Medicaid Health Plans, in partnership with Aetna Better Health of Illinois, Blue Cross Blue Shield of Illinois, County Care, Meridian, and Molina, we pulled together a toolkit to assist providers to recharge, you know, routine immunizations for children in Illinois and talk about COVID. There's scripts for phone calls, there's examples for text messages, there's different letters or email templates, and examples for graphics as well as hashtags that can be utilized. And then one of our other amazing partners who are not on this panel today, but who we work with frequently, EverThrive, also developed a campaign for parents and adults. And I think Dr. Chandra, one of the amazing things that you talked about is these different personas require different language, different conversations, and that require us to practice, you know, between colleagues and professionals. But it also takes, you know, an active research and, you know, actively learning the appropriate language. And what I love about EverThrive's toolkit as well is they utilize different language and imagery for the parent campaign and toolkit, as well as for the adolescents, knowing that how we have these conversations with an adolescent might be different, and because they're different and than the parents, and what their concerns are might be different than the parents. And so there's the toolkit that's for the providers in the community, our toolkit, and then we also have the EverThrive one, and then as well as this amazing recording and resource that we'll be sending around and circulating, as well as posting to our website so that you can share this with colleagues. All right, with that, Doctor, I know Chandra, we talked through a lot of amazing things about vaccine hesitancy, and that's why we are here today. But we received a lot of questions also about talking about, as we think through language and narrative about vaccine hesitancy, providers are having to have conversation about mask hesitancy as well. And they wanted to know if you knew of some other amazing resources or other things about how to have conversation about mask hesitancy, or if you yourself have been thinking about how to communicate that with parents as well as your patients.
I think that is a fantastic question. Um, I, you know, it's actually it's something that I want to do a little bit more research on. I refer a lot of my parents to the CDC website regarding things that we know that have been tried and true to help protect our patients and parents against COVID spread. Anecdotally, I will tell parents all the time, "Eh, look at how little upper respiratory infection we saw in our pediatric patient population over this past year when adults were all masked. I mean, and it was amazing to me, Maya, as a private healthcare provider, I could count on one hand how many asthmatic patients I saw with upper respiratory infections. Bronchiolitis was basically gone all winter, this past year. So just anecdotally, I would say that, mask wearing and staying home when you're not feeling well really made a difference in respiratory infection spread. I would like to see an actual, study that shows that mask wearing has made a difference. And I do believe that there are some studies internationally, and the CDC does cite, that mask wearing is very, very effective. But it does take just sort of getting to a parent's level to really understand, why are they so worried about wearing a mask? As a pediatrician, my number one priority is to get all of my patients back in person school. And so for me, that seems obvious that I'm going to do whatever I can to get them back there. And the children that I take care of really haven't been a problem in terms of wearing masks. So I just think it's important to reinforce to parents and patients that mask wearing is safe, that it has anecdotally at least shown me that it really has decreased the spread of respiratory illnesses. And it's one more level of protection that we can provide while we are trying to get as many people vaccinated as we can, so that we can get back to some kind of normal in-person education and normal in-person activity that is so important for our children to get back to.
I also loved your part during today's presentation about rethinking how the language we use when we talk about our members, as we refer to them, or patients, instead of categorizing them in these sections of low income or by identifying markers based off of maybe their political affiliations or other identifying markers such as that, and reframing it under that persona. I thought that was a really fantastic way to take off stigma and reapproach the conversation. And I think that same thought process can be applied to the masking. And when we are encouraging or talking about resources, we really take away that part of the American politics system and really focus and hone in on that academic element, or having conversations about whether it is that anecdotal experience, but show the proof of the safety of masking and across Illinois and across the country as well, and show evidence that it's effective. Really brings it back to that medical perspective and that authority space that you as pediatricians and providers have
I think
as well.
Well, I think it's important to not put somebody in the defensive mode from the get-go. I think that makes putting somebody on defense really makes it hard for them to change their stance. And so, as opposed to sort of an attack with a defense, it's better, I think, to try and work together with them, to come from a place of authority because this is what I do every day, but to not make a person feel like they have to defend their position. And so I think that level of sort of conversation is really, really important to have when it comes to improving things like vaccine hesitancy or improving things like mask hesitancy. It's just really important to get your patients and parents to buy into why you are talking to them about this, that it's really for their safety, and that you have taken care of patient after patient after patient with some level of authority now to say, this is what experience has shown. And I appreciate that it's not what we all want to be doing, but it's really what is the best thing to do right now.
Mm-hmm. Yes, because ultimately parents want to feel empowered and informed to make decisions about the best way to provide care for their children. And I couldn't agree with you more. I think that's fantastic. All right, moving along to some of the questions we received also from our attendees today. What do you have to say to a parent who has a family member that is a 1 in a million child with an adverse reaction to a vaccine? The parent doesn't only blame the vaccine, but should they choose vaccination will cause dissension among family members. How do you have conversations about vaccine hesitancy and vaccine confidence, not with the direct parents, but when they have conflict with other family members within their or friends in their inner circle?
That's a really, really tough situation, and it certainly has happened. Where, for example, I'll have a family who has another, like a nephew or a family member who they really feel had a problem due to a vaccine. And again, I think helping them with data is probably one of the only ways to help them through this, because they're already coming from a place of high emotionality. So giving them the data that we have, science data that says this is the rate of potential side effect or an adverse effect, showing them data from the VA-ERS system, and really just trying to help them understand, statistically, what we know, because they're going to come with full force emotion because this is their child. And sometimes you can't change their mind about it. And that is life. Sometimes you just can't change their mind about it, which is why I think it's important to really focus on the people who you can positively influence, because in the end, hopefully they will be protecting the children who have not been vaccinated, just by community immunity or herd immunity. So it is a tough situation to be in. I've had families who have lost relationships with other family members because they think it's important to vaccinate, and let's say a favorite uncle decides not to vaccinate their child. I've had families where this has happened, and it's really, really tough. But at the end of the day, everybody really has to think about what they want to do that's best for their child, and how to safely, carry out what we think is the right thing to do for their child.
I appreciate that feedback. We also received a question about, as we talk about vaccine hesitancy and confidence, we also have to talk about the social determinants. And maybe sometimes there's the prioritization of the family, or the needs of the family might be different, or might be just, placed elsewhere, or they might feel like there's barriers. And one thing I also wanted to address as part of this and some of the questions received, and remind those who are pediatricians or clinicians that if a patient is a Medicaid managed care member, providers are encouraged to remind patients of services Medicaid MCOs offer to improve access to those, and as part of that, there's transportation available. And so I also want to redirect everyone and encourage people to check out our toolkit, because in there we actually have a page talking about improving access to services, and include transportation contacts for our health plans, including the numbers and information and details about that. Additionally, if there is also a need for translated material in a preferred language, there's also ways for you to reach out to your member services at your health plan to get those. And those are also great ways to decrease maybe barriers in transportation or in language. As we continue these discussions internally and externally with colleagues, we don't want transportation to be a barrier. Unfortunately, we are wrapping up, and I know that there's so much more to discuss. I guess my last question is, if there's only one thing that our listeners walk away with today, what do you really want to impress upon our listeners today?
Be the source of information for your patients and parents. It is really, really important as healthcare providers to be that source for them, as opposed to having families get information from other sources which are not necessarily as trustworthy or scientifically based. Have have literature for your patients to read about, put it on your website if you have that ability, have conversations early on so that they understand your viewpoint about the safety and value and efficacy of vaccines. But it's really, really important to establish that trust with your families and then become their authority figure on things that are healthcare related.
Really appreciate that. With unfortunately, we are at time with that. We are going to have to say thank you for taking this hour to learn more. Visit our website at IAMHP.net to learn more about what we're doing at IAMHP and to watch other helpful webinars like this one today. Also, like and follow us on Facebook, LinkedIn, and Twitter to learn more. We are going to be having more webinars and podcasts about vaccines, hesitancy, well child visits, and immunizations, and we would love for you to continue the conversation with us. Additionally, if you are interested in becoming a trusted partner, I encourage you visit our website at IAMHP.net so you can learn more about that. Have a great day and stay safe and stay well. Goodbye.